PCOS is polycystic ovarian syndrome. It's dictated as a syndrome because it's actually a collection of symptoms that we don't have a clear pathway towards. We do know that it's associated with increased testosterone, which is the male hormone in the female body, which causes some of these symptoms to occur. And we do know that women that have PCOS can have difficulty conceiving and growing eggs and follicles. PCOS, because of the multiple symptoms that it can have, requires us to use a set of criteria to make the diagnosis. Usually that consists of irregular bleeding, either some sort of visible elevated testosterone level like facial hair growth, central body hair growth that the woman removes, or some blood work that shows elevated testosterone or other testosterone-like compounds in the blood, as well as some sort of ultrasound investigation into the ovary. Because of the name polycystic ovary, we know that the ovary is a responsible diagnostic criteria for that. But a lot of the differences of opinion on PCOS actually come because we don't have a clear, definitive standard for making the PCOS diagnosis. And so you may see a practitioner that says, okay, you don't have PCOS. And then you may see another practitioner that says you do have PCOS. And a lot of times that comes from a different criteria that that clinician is using to make that diagnosis. And it's really our admission that we don't yet fully understand the process of PCOS and what PCOS means in our standard patient population. We do know a lot of the side effects of PCOS, and we do have ways that we can control PCOS, but it is still a very difficult thing to make the diagnosis. I will say, by definition, it is what we call a diagnosis of exclusion. What that means is I have to exclude other reasons why someone might have irregular periods, why someone might have central body or facial hair growth or elevated testosterone levels in their body before I can say that it's likely or more likely PCOS. When we talk about polycystic ovarian syndrome, I see a lot of women that come in saying that they noticed a lot of cysts on the ovary, and I always get questions about, is that a good thing? Is that a bad thing? What does that mean? An ovarian cyst is really just a fluid collection within the ovary. It isn't descriptive in any capacity other than that, and so a lot of times we use other markers. So how big is it? How small is it? At what time did we see the cyst, and does the cyst change with time? The vast majority of cysts in the reproductive years are very benign in nature and either resolve spontaneously on their own or don't cause any issue. Probably the most common cyst that you will hear about or see is an egg or a follicle, which at its most basic level is actually a good thing. The more of those we have, the more access we have to eggs and or follicles. If you undergo an investigation and you have a really large ovarian cyst, your doctor may decide to follow up with subsequent ultrasounds, or depending on how it looks, even consider blood work to investigate what that particular ovarian cyst is. I see a lot of patients come in who are having their progesterone level checked by their general physician around cycle day 21, and either it's really low or it's actually negative for ovulation. Progesterone is one of those things that's made after the egg releases as a pregnancy is trying to form. That's actually really the only site that we get progesterone production from until a pregnancy is established. And so a lot of what we do in our practice tries to help the body make its own progesterone. Some people will have progesterone monitoring and then be started on medicine to elevate their progesterone, but in our practice, trying to help the body make its own progesterone with something like Clomid or Letrozole has been most helpful in people achieving that goal. When we talk about trying to manage progesterone, especially after we've done some of the things that we can do and adding supplements, there's a couple ways that we can administer progesterone. One of them is in an oral capsule, one of them is placed vaginally, and another one is in an injection form. And depending on what therapy you go through, we use different ones for different reasons. Probably the most important thing to realize with those therapies is that they are formulated in usually some sort of peanut or sesame oil. So if you have an allergy to any of those things, please let your physician know. When we look at treatment for PCOS, a lot of that discussion comes around what symptoms are you having and what symptoms are bothersome to you, as well as what are your goals at this time. As we've talked about, PCOS comes with irregular periods. The question is are you trying to conceive right now, and should we address the periods, or should we try and help you conceive? That's the major branch in my reasoning. Traditionally, if someone wants to control their period, something like a birth control can be really helpful in controlling the period, can help prevent pregnancy. It is also very helpful in addressing the elevated testosterone in the system, so it can help a little bit with the facial hair growth or other symptoms that are bothersome to women. Now, unfortunately, that means that that treatment modality doesn't make sense if you're trying to conceive. And so, as we've talked about before, trying to elevate the body's own natural production of an egg follicle and ultimately progesterone is the best way that I can help people with PCOS conceive. So when you are looking at the treatment of PCOS and irregular periods, it's important to classify what that looks like and which one is maybe more concerning than the other. I would say all irregular periods are worth investigating and worth mentioning to your doctor, but for sure, if you go more than 3 months without a period and you're not taking any like oral contraceptive pill, any progesterone pill, or have an IUD place, anything like that, then let your physician know. The biggest concern is that if your body's not making its own progesterone, the endometrial lining could overgrow and become abnormal. And that is a risk factor for developing endometrial cancer in the future. So being really aware of your period and how long the spacing is important in seeking care and treatment for PCOS. When we consider the treatment of PCOS, a lot of that discussion goes into what is your goal at the time and what symptoms you are having. A lot of my patients that I see want to conceive at that time, so a lot of my focus is on what can be done at that time. Some other patients may want to address the abnormal bleeding or the facial hair growth. One of the common pathways and things that can be done, no matter which pathway you're deciding to choose, is a focus on the daily lifestyle things that are happening that can improve your overall health. Because we know improving your overall health can improve the symptoms of PCOS. Primarily focusing on a healthy diet can be really helpful, in addition to exercise, with the goal of weight loss in mind. We do have a decent amount of evidence that if we can lose 5 to 10% of our total body weight, that can be enough to restart normal periods. It may even be enough to help with ovulation and help someone conceive. So that's a very decent pathway to address both the bleeding and your ability to conceive. Some other things that can make PCOS worse is tobacco consumption, so limiting smoking as much as possible and quitting can be helpful, as well as limiting alcohol consumption. Those are some things that can help in the PCOS process recovery and potentially work as some level of treatment for those different conditions.